This is probably my favorite topic, something that's been near and dear to me for a long, long time, and I love to share it with restorative dentists. And you could argue that this is really a restorative class, even though we're talking about a perio topic. And I say that at the workshops too. This is a restorative class. This is geared to help you as restorative dentists solve some of your everyday restorative problems, get better results, as it says in the title. So I've got several things in mind for today. It would work better. You know, we brought up that that little box, and that seems to have taken away my, there we go. I wonder if having the chat box caused some of that problem. We'll try it again. No, it still works. Okay, so my goals. I want to talk just for a little bit today about saving teeth. I think today, with the idea of implantology and implants and titanium being a solution so many times, we lose sight of the fact that a lot of teeth could be saved. I also want to share some benefits of using the crown lengthening concept, solving everyday restorative problems and also solving everyday aesthetic problems, restorative or not. And then we'll spend a little bit of time looking at the actual definition of crown lengthening, if you look in the current procedural terminology manuals, insurance manuals, etc., and how that definition applies to what it is that we're trying to accomplish. And then we're going to talk about bone. I know you think mostly, and you look at the mouth and you see soft tissue problems, but I want you to see that bone is actually a big, big issue. And then at the end, we'll go over a few cases. By then, some of these concepts should make sense. So we'll start out with the idea of simply saving teeth. So I look back in the dental literature, I have it here somewhere. This was a few years ago, 2016, so not that many years ago, a one-page editorial, and you can see the title here. Are dental implants a panacea? Dental implants a panacea? Or should we better try to save teeth? And what these editors wrote, I'm going to read you just a couple of sentences. They said, a trend affecting clinical practice over the past 2 decades, and this is already, what, 4 or 5 years old, over the past 2 decades has been the reduced emphasis to, quote, save compromised teeth. And they go on to say, as such, many teeth are being condemned at early stages given the expediency that lends itself to quickly rid a problematic tooth and provide instead a tooth implant. Then they go on to say, and this is really interesting, the erroneous belief of implants yielding a better long-term prognosis has now clearly been rejected in several studies and reviews. And on the second page of this review, they list 12 or 15 of these articles, and that was 5 years ago. So there's quite a few more now that are actually out there saying that maybe implants are not the panacea. Then they say teeth, even compromised because of perio or endo. Teeth compromised by perio or endo could surpass by far that of the average implant. So not my words, editors, Journal of Restorative Dentistry, Journal of Dental Research editors saying that implants are not the panacea. So I want you to keep that in mind. And then there's a colleague down in Florida, Danny Melker. Some of you, I know some of you are on already from Florida. Danny Melker is a periodontist who prides himself in having not done any implants. And he shows an example here where I can see why some people would be intimidated with this tooth from a restorative standpoint, very poor retention. But by applying these principles of, well, I like to call it actually gum shortening or crown lengthening, as you're used to hearing, that we can actually expose more tooth. And I think you would agree, have a very appropriate restorable situation. So let's give you a couple more examples how we can solve restorative issues by applying these principles. So here's Brad. He's still in his 30s. And it's unfortunate that we're redoing his bridge work due to sensitivity and caries. And you can see here, after the existing bridge was removed, it would be a challenge to get a good impression underneath all this tissue. Can you see getting a good impression like you see here from my friend Tom Piccolo, that the margins are visible everywhere, you know, I think it would be difficult, and I think you would agree it would be difficult, even if you did one tooth at a time, it would still be difficult. But you can see here after the gums have been shortened, tooth has been exposed, you now have the opportunity to choose wherever you want to put your finish line. You could stop right at the tissue if you like that, or just a ½ millimeter under if you prefer to hide the margins. Whereas here, it would be continually challenging. Let me give you another example. And here's the red flag story that I've heard so many times over the years. People come in, like Lisa, and she says, ever since I've had this bridge made, my gums hurt. Ah, that's the red flag. Ever since the bridge was made, my gums hurt. And you can see here funny looking margins, and here an open, short margin. And when you do get the bridge off, you have what somebody called a buildup and a very, very short prep. And you can see why it would be difficult to have good finish lines, good retention. After the bridge is remade, you can see the changes that you benefited from shortening the gums. We've exposed more tooth. Once again, now you can keep your margins right at or just above, or really in this part of the mouth. Why not make a supra gingival margin? I think there'd be no reason not to. But you can see here very nice finish lines because you've exposed the tooth and shortened the gum, and you have complete access. Yet another example, solving basic restorative problems. Robin's dentist is having trouble keeping the provisional crown on the second molar. So let's take a look at what the problems are, what the cause of the problem is, and a solution that I think the periodontal procedure can offer to you. Take a look here at the amount of enamel that you see. A lot of it's hidden under the gum, and you can see here more enamel showing. Why was it hidden? Well, here's the problem. Once again, bone. You see all this thick area of bone? How do we then resolve this problem of not enough tooth? By taking away the bone that was up here. And when we do that, we also do some scalloping around the roots to establish normal biologic shape. And here's what we started with. You can see probably this might be the reason why the provisional wouldn't stay on. But you can see here after that not only is there tooth structure, that you now can have a preparation to get proper retentiveness, proper ferrule, but you also have more enamel showing, that is an illustration of how much more tooth you've created. And without having to impinge on the tissues at all, you can have good parallelism, so you have good retention, and you can have crowns that don't irritate the tissue. And you can see here that there's plenty of tooth structure to have done that. Another red flag story. There's so many stories like this. People come in, they tend to have the same story. So in Larry's situation, he comes in and says, same story. Ever since I've had these crowns made, my gums hurt. Can you make me better crowns? Now, my pointer is disappearing right here because I'm bumping into the pictures. Did my pointer disappear? I'm not getting feedback. So
you're good. You're good. We can see
the
it.
The pointer's still there. Okay, because I couldn't see it. Thank you. So you can see here how the crown looks rather short in this dimension, and this crown rather short in that dimension, plus open margins. Now, here's what I want you to do. I want you to look at that crown. Let's focus on the second bi and the first molar, and try to picture in your minds, what is that crown going to look like when we take a look in the mouth? What is it going to look like? Since we can still observe half of the anatomic crown, the restorative crown only covers about half the anatomic crown. What do you think it's going to look like? Rather small is what I'm saying. So look at that. This is not a normal appearance for teeth. These shouldn't be that short, but they are. Why are they that short? Was there a gum problem or was there a bone problem? Well, you're going to argue it's both, you know. So, but I want you to see after the crowns are removed how little these teeth were. Why is the gum up this high? Is it because there's too much gum? Well, I'm here to tell you that I believe it's because there's too much bone, and you get a sense of it right here too. And the dentist who put those crowns on knew he or she had a problem. Look at all the retention grooves. Look at all the retention grooves. So they were able to keep the crowns on, yes, they were, but by reaching down under the soft tissue to grab some tooth structure, because they didn't have enough available, they caused all that impingement, which caused that red, irritated, sore gum that led to the red flag question of, ever since the crowns were done, my gums hurt. You can see now with the provisionals on that the tissues already look better. Why would they have gotten better? Do you say, well, maybe I really had an allergy? Did you have an allergic reaction to those crowns? I'm sure that you might think that. It makes sense that that could be the problem, but I want you to not lose faith in what I'm telling you. This is an impingement problem, and you can see it right here. You see where the finish lines were? The original finish lines, they're practically touching the bone, aren't they? So they're clearly within the biologic width. They're clearly too close to the bone and impinging on the soft tissue. How do we resolve that? It's not a matter of resolving the tissue issue. It's a matter of resolving the bone issue. Pun was intended, the tissue issue. So we take care of the bone, and you can see here scalloping, thinning, sluicing. Even if we hit a little marrow space, it's okay. And when the tissues go back, the soft tissues go back, look at how much more tooth we've exposed. And notice the open margin there, the open margin here. Look, huge open margin. In other words, these provisionals are nowhere near the place, the level of where the restorative crowns were. They're nowhere close to that. This is the reason, in my opinion, why the tissue looks better once the provisionals were on for a while, because we relieve the impingement with these margins right there. So now we have a chance to allow the tissue to heal. You can see how little tooth was there when the dentist went to do the original restorations. And now after the gum shortening, the new dentist is re-preparing the teeth, and look at how much more tooth they have available. Quite a bit more. Easy to do a restoration, easy to have enough ferrule, easy to have retention, easy to put your margins where you want and avoid impingement. And how do we do that? Not with a gingivectomy, not with tissue management, but with bone management. That's what I want you to be aware of. And there is enough tooth structure there. No, wrong button. There's enough tooth structure there that we could have supragingival margins here. The dentist didn't have to reach under the gum to the point of impingement again. They could keep the crowns away, let the tissue heal, have plenty of retention as well. So that's what I want you to be thinking about. So what are the clinical implications? Was there too much gum tissue? Was there too much bone? Or was there not enough tooth structure? Well, clearly there was enough tooth structure. The amount of tissue really doesn't change. It's just in a different place. It's too high up. And why is it too high up? Well, it's too high up because this is a bone problem. So what do I want you to take away from this? Take a look at the x-rays. Have a sense that something's going on. The x-ray really will give you information that you can gather that that crown looks funny. Open margin is funny. The size of the crown is funny. All of these pieces of information are there for you to take away from the x-ray. So now, we're still solving problems. What about solving restorative problems? So here's an illustration from somebody, actually, I'm very proud of what he did that took my workshop. And this was Neil's first case. He said he almost referred this lady out to solve the aesthetic problems. And then he said, you know, I think I understand enough to do some shortening of the gum, take the crowns off, do some shortening of the gum, and do his restorations. So if you understand that this is not a gum problem, this is a bone problem, and whether you're doing the, I have no way of knowing how many of you are doing these procedures or not, but you have the opportunity, if you're doing it yourself or referring to a surgical colleague, to have bone adjusted here so that you can have taller teeth and solve your aesthetic restorative problems. So I've given you my thoughts about saving more teeth in this era of titanium deficiency, talked about how These concepts can help you solve everyday restorative and everyday aesthetic problems. So now here's another little interesting twist on this term crown lengthening, even though I like the term gum shortening better. By definition, crown lengthening is something that's done to benefit you from a restorative standpoint, and it's done by means of a flap and bone surgery in a healthy environment. So that means it's not periodontal disease management. That's a different code number. It's the same idea of a flap and bone surgery, but it's done in a diseased environment. Crown lengthening, by definition, is in a healthy environment, flap and bone surgery. So therefore, when you go to your next conference and the laser rep tells you that you can do some aesthetic crown lengthening by using their laser product, by definition, that's not crown lengthening because there's no flap and there's no bone surgery. So this laser concept can get us into trouble if we are not careful. The reps sometimes, not all, lead us to believe that we can do this with a laser gingivectomy. But I say that that's not really the case. If you do just a laser gingivectomy, then you have the potential for the gum to grow back because you didn't adjust the bone. So here's an example right here with Jill, laser gingivectomy, teeth made to look taller, crowns placed. What happens to the gum? They grow back. And when they grow back, they bump into the new restorative margin, causing that impingement. Another example, even more extreme, with Dara, laser gingivectomy, crowns or veneers placed, gums grow back, bump into the margins. Compare the tissue on these two young ladies to a healthy site, pink, stippled, knife-edged, as opposed to red, enlarged, swollen. So the laser concept, if we're not careful, can get us into trouble. And what I want to talk about when you're thinking about, can you do a gingivectomy? Do you have to do bone surgery? There are times when you could do a gingivectomy, but let's talk about that. The biologic width, the dimensions of human gingiva that were introduced to our profession was in the 1960s by our colleagues in Chicago, Garagiola, Wentz, and Orban. Orban, you've heard that name probably before. We've learned that we have typically about 3 1-millimeter dimensions comprising the biologic width. A millimeter for connective tissue, the epithelial attachment you see here on the root, and a millimeter for sulcus, totaling 3 millimeters. So that's what the body wants. And if you cut the gum off, by the way, at the gum line and give it time, it grows back to what? 3 millimeters. That's what it grows back to, because the body knows. So therefore, if you keep that in mind, and you see here 5 millimeters probing under anesthesia to the bone in a young girl, 5 millimeters, and you understand that 3 is the natural dimension of human gingiva, can you see that here you could cut away 2 millimeters with your laser and do a laser gingivectomy? But that's not always the case. So that's one of my other implications. Think about that. If it's 3 millimeters, you have a different problem. Well, John Coyce, one of my also favorite educators, besides, of course, the Pankey Institute, John is one of my favorites. He has helped us to understand these restorative perio relationships. And here's one of his articles where he explains how the bone, not new for you tonight, right? How the bone and the symmetry of that bone impacts the aesthetic symmetry in the soft tissue. So he's showing asymmetrical bone and symmetrical bone. Now, take a look at this. Valerie, exactly like in John's article. We've got asymmetrical tissue. Why? Well, we're going to find out. Potentially asymmetrical bone. So let's probe under anesthesia and see what we have here. 3 millimeters to the bone. 3, 3, 5. Okay, that's good. 3, 3. So if you have a 5 here, you have a sense that the bone isn't there, that you could do a gingivectomy like I just showed you. Okay, so now let's probe again. 3, 3, 3, 3. Uh-oh, this one's different. Why is it still a 3 even though the tissue is lower? Well, because the bone is in a different location than the adjacent tooth. How do we fix that? We go to the bone level, we make the bone symmetrical, as John has shown us in his article, and that's how we make the soft tissue symmetrical. It's all about bone and soft tissue following the bone. So what I've tried to do so far is show you my concepts on, well, not even mine, I'm reading you that editorial, saving teeth, benefits from restorative and aesthetic issues, and the definition. So this is a time where I was going to stop and see if there were questions, but I'm not sure how this chat box is going to work for me. I got Richie's note. That was early on. Thank you. Welcome. Participants will receive. I'm looking for questions. Looking for questions. Fairfield County, Connecticut. Study Club. Hello. Maybe I know some of you. You missed the star code. I'm looking for questions. All of this is logistical stuff. 3 new messages. Maybe that'll be a question. Any research, here's one from Richard. Any concern about recession following anterior crown lengthening? If you put the bone where you want it, well, you know what? You're going to see some cases as we go toward the end of the hour. If you put the bone where you want it and the tissue like 3 millimeters above that, it is very, very stable. When might you have recession? If you put the gum tissue up higher, you didn't give it enough time to heal and stabilize at the 3 millimeter level, you could get recession. But no, if you put the gum 3 millimeters above the bone, it's very stable and we can show you long-term results. But that's a fair question, a good question and a fair question. I thank you. So can there ever be a time when lasers cannot be used for aesthetic cases? Lasers could be used. I'm not, and actually I'm really glad you asked that question. I'm not anti-laser. I'm anti-failing to understand the biology. And these laser reps, bless their hearts, you know, they're out there trying to sell us their products that they believe in, but they may not always understand the biology. And so therefore, you can use the laser. I show in my workshop somebody that's very fond of using lasers, and he uses it in the same way I use a scalpel and a burr. So it's not about the laser. You can use it to make your flap. You can use it to do your bone surgery. I'm just against the laser companies that might mislead us into thinking you can do a laser gingivectomy when you only have a 3 millimeter biologic width. So that's an answer to that question. Do you prepare the teeth before or after crown lengthening? Actually, I'm not going to have a lot of time to cover that tonight, but I'm going to answer the question because it's so important, and it is covered in the workshops. You're going to prepare the teeth before, because I'm going to recommend that you take off pre-existing crowns. How else do you know how much tooth structure you have under there if you don't take off the crown that's there previously? So you're going to prepare the tooth, you're going to put on a provisional so you can see how much tooth, and then you get to prepare it again. So I'm sorry that you have to do 2 sets of provisionals, but that is the way it works. More questions? Sign in, that's logistical stuff. I've noticed that anytime a gum is recontoured and a temp is placed, after 2 weeks when patient returns, the gum overflows over the margin. Any tips to avoid this? Let's see, the gum is recontoured and a temp is placed. So that question relates to what I said earlier, that if you don't modify the bone to where you want it, you put the gum back, it will grow up because you didn't put it in the right place relative to the bone. What will keep the gum where you want it is putting the bone where you want it. But let me give you an example. If you think back to the biologic width, well, maybe I can even go back. Nope, I don't want to go back too far. So if you put the gum, wait, let me see, what was that question? I lost it. That the gum grows back. Is that what the question was? So if you put the gum too close to the bone, it is going to continue to grow. We're going to address that here in a few minutes. So I'll look for a couple more questions that I can answer for you. There's so many of you here, and there's so many, there's over 300 of you here, and so there's quite a lot of questions. How many weeks before taking the final impression? There's a lot of different opinions, but I would say, especially in the anterior, 3 months minimum. In the posterior, if you're looking at doing supra-gingival margins, then you could go in there much sooner, because you're not, as long as you're more than 3 millimeters away from the bone. What is the most predictable way to determine the bone level? Probing under anesthesia. So I really can't answer all these questions, but I'll try to come back to them, and we'll try to answer more at the end. Now, if I can get the slide to advance again, there we go. Okay, next topic I want to address, and I think we will have some time at the end to cover some more of these, is more examples of why bone is the issue. And this may answer some of those questions about, this will answer that question about where do you put the tissue and where do you put the crown, and what happens when somebody said they've seen the gum grow back more than they wanted to. We'll answer it right here. So Orla had these crowns placed and the gums were sore and red. Now, it did not bother her that the crowns were shorter on the centrals than the lateral incisors. Never bothered her aesthetically. It bothered her because the gums were sore. So how do we resolve that? As I said earlier, we take off the crowns, we place provisionals. So this is what I was trying to show you when I said, oh, maybe I can go back. This is exactly what I want to show you. Our goal for the restorative margin is no more than a ½ millimeter below the tissue. And how far away is that from the bone? Well, here's a millimeter of connective tissue, a millimeter for epithelial attachment, and half the 1 millimeter of the sulcus. So that crown margin is 2.5 millimeters from the bone. If you put the crown margin too close to the bone, that's when the gum is going to grow back more, and you could run into the impingement problems that you saw. So let's take a look at Orla. Here's the provisional. We're going to seat that. So that margin now is going to end up no more than a ½ millimeter subgingival. That would be best. But you can see here that it's going to go and get seated a lot more than a ½ millimeter. When we seat that crown, those two crowns, the two temporaries, look how close they are to the bone. Here's the key to understanding the relationship between bone and biologic width, right here, next picture. We're going to correct this by correcting the bone. So you see here, we want to clear at least 2.5 millimeters from where the new location of the restorative margin will be. At least 2.5 millimeters right here, 1, 2.5, retaining your ½ millimeter of subgingival margin in the aesthetic zone. And then here's the key. Somebody said, well, sometimes the gum seems to grow back. Well, if you put the gum back here at the level of the bone, the gum is going to grow back. So instead of that, we're going to put the gum about where we expect it to end up, namely right here, namely about 3 millimeters from the bone. So you have your biologic width already built in. All that has to happen now is the tissue just heals. It doesn't have to heal and grow back. So I hope that answers that question. And here's the final result. Yes, we've made the central incisor crowns more proportional and symmetrical the way the ideal smile line is, but that was never her complaint. Her complaint was just the soreness because of the impingement. But we solved that problem by managing the bone. A couple more anterior aesthetic factors. Here's Denise. She is interested in eliminating her gummy smile and the diastemi without doing ortho. She's willing to do the surgery. She's willing to do restorations, but she doesn't want the ortho. So the dentist does his laser gingivectomy. Ah, but you said that's not good. Well, let me explain. He does his laser gingivectomy on the day of creating the provisionals. The same week, the patient comes back to me, and look what we've got. Since he did a laser gingivectomy yesterday and made taller provisionals, just as we've talked about, the margin now is too close to the bone. We have the exact problem we just had with Orla. You see that? How do we correct it? Same way. We manage the bone, and where do we put it? Relative to the new location. Well, new because it's a new restoration. The location of the restorative margin, 2.5 millimeters. Why? What happens? 3 millimeters of biologic width develop. The crown margin ends up a 0.5 millimeter sub G, still 2.5 millimeters away from the bone. And we predictably solve her aesthetic problem, and we could put bigger crowns on there to solve the aesthetic problems. And then the question was, how stable is that after you've done your restorations? And I say it's extremely stable because the body wants to maintain the biologic width. Another anterior aesthetic problem solved by understanding these measurements. Carol wanted whiter, brighter teeth, which, you know, you could debate that she needed or didn't need, but the dentist said, if you're going to do that, why don't you get this gum shortened? So she did. We shortened the gum in both these locations, and I think that you would agree that the aesthetic result is greatly improved as a result of shortening the gum before we started. So it all comes down to understanding the relationship between the bone and these restorative margins. So it's not just the gingivectomy. It's understanding bone. That's why you can't just do a laser gingivectomy. That's why it kind of bothers me. And I see it as a periodontist, the kind of cases I showed you with the two ladies before, Jill and Dara. All right, another example, how bone is the issue. You have to think through these things sometimes. Now, I put that rocket slide there because my cousin's husband is a rocket scientist. So I called him up one time, Steve, I'd like some photos. Help me out with some unusual photos from your NASA archives. So he sent me a few. This is one of them. And I put it there because I want to tell you that though this problem with Paul might be a little unusual, it's not atypical. And it's not rocket science. I want to give these basic principles because I think you can apply them in everyday restorative dentistry. So let me tell you what happened with Paul. He comes in and he says, you are the 4th dentist that I have seen, and if you don't solve this problem, I want my tooth extracted. What's the problem? Red flag. Ever since I've had this crown placed, I have an odor here. Every time I put floss in there, it comes out and it smells. I don't like that. So this is my last try. I said, well, look, go ahead and have the crown removed. I just said that to you before. Have the crown removed because I have to see what's under there. Okay, well, gee, there's not a whole lot under there. This is a rather small prep, barely enough room to have buccal and lingual ferrule for stability and retention, barely enough. Buccal and lingual being the most important places. And the margin is actually quite a bit subgingival. Why? Well, once again, bone is the problem. There was an article by some periodontists a few years ago where they kept track of every maxillary flap they did, and they found out that 79% of people had this exostoses, this rigid bone here. So that's why the gum ends up too coronal, and we end up with difficulties with our margins being subgingival, hurting, like you saw with Orla, you saw with Larry. Here's an example where it was an open margin that didn't hurt, but still had a red flag issue that bothered him. And you can see when the gum and the bone are removed, how there's an open margin there. I'm guessing, because I didn't take that crown off, that was the same problem with the crown before. So how do we solve it? Same way. bone management, smoothing out, raising the bone, allowing the crown to be made. Look at again, supragingival margins, supragingival margin, because we manage the bone. Here's the pre-op x-ray. There was nothing on the x-ray as compared to Larry, where there were obvious things on the x-ray. Nothing on the x-ray, but again, as I said, it's not rocket science. Something's wrong. Trust me enough, Paul, to go back to your dentist, take the crown off, let me inspect underneath there. I don't know for sure what I'm going to do, but I have to see what's under the crown. He trusted me. He went back, took the crown off, found the problem, took care of the bone, and the bone solved the issue. So what are the implications there? It's not rocket science. Look around, think about it. The x-ray was the answer with Larry, and it will be with some others I'm going to show you here in a minute, but it's not always the answer. You have to use your head, you have to be a detective, and you have to think through these things. All right, next thought. Sometimes you worry, if you're considering this procedure, that if you're going to take bone away, that it might be a problem and make the teeth unstable. Well, I've put in this one example to let you know that that's not something that you should worry about. Here's a really good example where you might worry about it, because Kathy had ortho, but the dentist now says, I really can't restore this open margin. It's way down underneath there. So we thought about it. We both wiggled it. We gave it a lot of thought. Tooth was rock solid. We went ahead and treated it, despite the short roots, because I know from the literature that we don't take away enough bone to make these teeth unstable, even with the short root. And here's just one article that explains that. 96% of the sites that they did in this crown lengthening study, they took away less than 2 millimeters of the bone. Now, you would be correct to concern yourself with making teeth loose in the place of deep periodontal pockets and a lot of interproximal bone loss. Yes, that could be a problem, but that's not the case with crown lengthening / gum shortening procedures. And so I wanted to share with you this little piece of literature to reassure you that you aren't going to make the teeth loose with these problems. So the implications of this case, think it through, be careful. It's not always clear, but collaborate. You know, I'm a specialist and I'm a periodontist, and I teach these classes to mostly general dentists. But despite that, I really do believe in a team approach. And I tell everybody at every workshop that they're not periodontists at the end of the day, and that they should go back and collaborate and be part of a team, because I think it's just so much better for everybody. And here's a perfect example. If I didn't have a teammate to kind of consider this, I'd be operating out there on my own, and it's reassuring to have a teammate to look at this and agree that we could go ahead and treat it. So I'm going to regret putting these questions in there, these slides to ask questions. I answered that one about, do you prepare the teeth before or after, because there's two. And here's a question about crown to root ratio, which I just addressed. Healing. Oh, these are the questions I've seen before. I don't know about the flawless aesthetic crown lengthening procedure. Sorry, I've not heard of that one, Ramzan. What do you recommend for disturbing the biofilm for maintenance of the surgical site after flap crown lengthening? Well, you know, I like to recommend that, especially today when everybody's worried about going back to work, that there's so many possibilities for a rinse before you do any procedure, that iodine, betadine would be an excellent rinse, because it kills the viruses, it kills bacteria, and it would help to disturb the biofilm. So if you wanted, I'm not worried about disturbing the biofilm, polish it away. That would be appropriate. Polish it away, use some of these antimicrobials to kill the viruses. Hello, please, that's a logistical thing. Oh, now I've got 11 new messages. Do you feel restoring dentists should know before prepping that crown lengthening will be needed to discuss with the patient, or is it something that is determined at time of prep? That's an interesting question. Do you feel restoring dentists should know before prepping that crown, before prepping, comma, that crown lengthening will be needed, to discuss it with the patient? If you can think back to Larry with that really little crown and the very irritated, chewed up, red, sore tissue, or even Orla with the red, inflamed, sore tissue in the anterior, I suggest you always tell those people that yes, you can make them a better crown. But, this is to answer your question, but there's a chance you will need a gum shortening, and I will let you know that once I have the crown off and I can look at how much tooth you have under there. So no, you won't know ahead of time. But anytime there's thick bone, too much gum, or these crowns that are really little or have open margins, you can pretty well be sure that they have open margins because too much gum, not enough tooth. And tell them that I'll let you know when I get your crown off. Oh, Lisa was a perfect example, that tiny little upper second molar. So you won't know until you get the crown. You'll have a pretty good sense, but you can tell them, you'll let them know. I mean, that would be logical. I have noticed anytime gum is recontracted tempus place after 2 weeks, the patient, the gum overflows the margin. Oh, that was the question from before. I think that the gum and the bone were not coordinated, which is why the gum grew back. How do you approach the buccal furcation if crown length is required in this area? If the previous crown goes down to, but not into the furcation, you manage the furcation by scalloping the bone over each root so the scallops come up to the furcation. If there is a problem in the furcation, then we barrel in the prep. So if you're looking down on it, it will look like a figure 8 barreled in. Again, that's something that I've talked about in workshops and lectures, because I have good examples of that, but not time for tonight. What about cases where the attachment is more than 3 millimeters, more than 2 millimeters? I understand the concern with that, not knowing exactly where the attachment will be when you're done. John Cloyce has helped us to understand that anytime we do a surgical procedure, the gum put back will heal back to 3 millimeters. So if you're starting out where the attachment is more than 3, it will end up at 3 once you put the bone at the correct place. What is the most predictable way to determine bone level? I think that I've seen these before. I guess that's an old one. We do it with anesthesia. Do you teach perio at CU? No, I do not teach at the university here. Any instances where I would recommend flapless crown lengthening for interproximal caries access? I'm not a big fan of a flapless approach. As you know, I've made a big deal tonight about the bone. I think it is about the bone. That's what I want to see and I want to manage. Plus, if we take the bone down interproximally, how are you going to see to lower the bone buccal and lingual? So you have to maintain that same biologic dimension, interproximal being more coronal than radicular. So no, I'm not a fan of flapless crown lengthening at all. What is the best time for final restoration? I did mention that if you're doing a supragingival crown margin, you could go in much sooner. If you're doing subgingival, you need to wait a minimum of 3 months if there were no issues with the healing, sometimes longer if the healing was slow. The suture I use is chromic gut. And actually, you know, this is not a workshop, but the chromic gut, by dissolving and breaking down and releasing the tension on the wound, is so much more comfortable than any non-resorbable suture. So for those of you doing this at home, I like the chromic gut. And then that somebody might say, oh, well, the chromic gut's hard to work with, but if you take it out of the inner package, put it in a glass of water, put it in a glass of water, let it sit there while you're doing the procedure. When you take it out of the water, it's no longer stiff. It's really easy to work with. I'm a big fan of chromic gut. What is your opinion about doing crown lengthening in those that are vital, not endo? Do they become symptomatic? No, I don't think that we cause endodontic breakdown at all. Should the general dentist always do gingivectomy and make a provision on the teeth before it goes to the periodontist for osteosurgery? There's no benefit in doing a gingivectomy because it's just going to grow back. That was my point with Larry. You can't just do a gingivectomy. So therefore, you take off any old crowns, you put on your provisional crown, and if you're working on a team with a periodontist, verify that they agree with me, but that's how I want. You can send the patient over to me originally with the crowns, but I'm going to return them with the suggestion that they have you take the crowns off anyway. Because I want to be able to remove those provisionals at the time of the surgery so I can see the bone interproximally. Makes it much easier. I can be more accurate. You see, if you didn't make that crown, you don't know how much tooth is under there. So you have to take the crowns off to find out how much tooth you have. And I need to know that so I know how much bone to take away. So to answer that question, no, don't do a gingivectomy. That gingivectomy that I showed you was only in the aesthetic zone, and that dentist did it for the purpose of putting approximately what the final resulting crowns would look like so that the patient is reassured. That's a technique that he liked to do, but for posterior and even for anterior, that's not necessary. Vitality affected if no, the vitality is not affected if the furcation is involved. This is a question that I don't even know. Let's see, how do I learn to do crown lengthening procedure like these? So somebody's asking about where you can learn to do these procedures. Email me later and I can tell you. I teach a few workshops at different dental schools and conferences, as Lee mentioned earlier. And depends where you are, maybe I'll be coming to a conference near you. Who knows? I just had a bunch of conferences canceled, as we all have. This is an interesting question. I think I know the answer. At what point do you decide between removing bone for crown lengthening and saving bone for implants? That's a dilemma these days, isn't it? But on the other hand, we're not taking away much bone, as I just addressed earlier when we looked at Kathy. So I don't think we're in any way impacting our ability to do implants at a later time. You should be able to make a determination that the tooth is restorable if you could get the tissue out of the way. And how do you do that? With the bone. So no, I don't think we're ever taking away enough bone that implants would be put at risk, ever. That could happen with severe periodontal disease where you already have bone loss, but we're not taking away that much bone. Can you put a start code in the chat box? I don't know how to do that. Do you cut the gum margins before suturing it back? Oh, yes, I do cut the gum margins, because if you take a situation like Larry, where you had those really, really short teeth, what I'm doing is when I scallop the flap, I'm taking gum away there, buccal and lingual, because then when they take the bone away, they're all going to fit back together. That's a question we do address in the workshops. And I'm not here to sell the workshops, but I'm just trying to say that these questions are great questions. It's just that they're covered in a different context. Please email, oh, that's from Dylan to all of you. When can we do flapless bone removal? I addressed that in another question that I'm not keen on that. Crown lengthening needed on one side. Would I only do crown lengthening on the buccal or the lingual? It does not always have to be 360. Good question. If it was a lingual cusp fracture or a buccal cusp fracture, you could do just that side, which is what we do in the anterior aesthetic region, as you saw with Denise. So you only have to do 360 if you've got the interproximals involved. Good questions. So after you've shortened the bone, where do you place the gums? Well, that's what I showed with the Orla case. We shorten the bone, the gums go at approximately 3 millimeters above that, so that's the 3 millimeter biologic width. If you put the bone down here the gum, at the bone level, it will grow back. But there was a nice study out of Italy that shows where they did that exact thing. They cut the gum off at the gum line and they measured every 3 months. Guess what? It took 12 months to grow back to a 3 millimeter biologic width. So you put the gum back at 3 millimeters above the bone, it'll heal quicker. It's attached to the bone at the level that it wants to be. After crown lengthening and posterior molars, do you prefer supragingival margins? Sure, why not? Why not assure yourself of having no potential for impingement in a non-aesthetic zone? It makes your preps predictable, your impressions a slam dunk. So I am a fan of it. How do you keep, this is a good question, and then I might have to leave the questions for a while. How do you keep crown lengthening creating too much space between the mesial of the first molar and second bicuspid distal when the restorative margin is deep and it's a food trap? We do take bone down equally between the two teeth, whether it's those two teeth or any other. And then we let the gum develop. You're going to get your full 3 millimeters of soft tissue, a little more interproximally as the papillae peak, and then let that heal, give it plenty of time, maybe 3 months minimum or longer, and then you make it up in the porcelain if there's still some space between them. Now, if you're only doing one crown on one tooth, not the other, you would have to bulk it up a little bit so that you avoid having the black triangle. If you're another question about workshops, please send me an email. You can Google my name and you'll find my website. Excellent, CE, thank you for saying that. Can you reiterate where your suture should go? Oh, you mean the flap suturing 3 millimeters above the bone? Which burrs? I can't really answer that question, but if you're interested in the burrs, send me an email. I'll send you some information on the burrs. Happy to do that. When bone sounding, is there concern of creating pockets? No, the tissue will be fine. It'll grow right back. So I'm afraid I'm going to put the questions aside. We'll see how much time we have at the end. But let me continue now with, the questions were great. I thank you for that. It's kind of fun. All right, cases. So I've given you my thoughts. You know from Dr. Pankey and the philosophy that he's helped us to understand that if we know ourselves, we know our patient, we know our work, which is what we're learning about tonight and on the webinars and at the Institute, and then you can apply your knowledge, you will enjoy the rewards that Dr. Pankey has helped us to understand. Well, now by looking at some of these cases, I'm hoping that it'll make sense to you and you'll be able to apply your knowledge. So the first case, crazy as it seems, I mean, she is not the only person to have told me this true story. So teeth can be saved. Here's Debbie's story. Before I had this bridge made, she tells me, I had a tooth here. The crown, she said, kept falling off. But the dentist kept replacing it. And he finally said to me one day, it's a bad tooth, Debbie, let's take it out. So she said, I've been going to this dentist my entire adult life. I trusted him. And I only said one thing. I said, instead of cutting down the adjacent bicuspid, could you at least give me a cantilever bridge so we don't have to cut down the other tooth? Dentist said, sure. You know what the problem was? You guessed it. The cantilever bridge kept falling off. Why is it falling off? Well, you see, the problem was that the tooth was, the crown was very small because the tooth had too much gum around it. Why is there too much gum around the tooth? Well, you already know the answer, too much bone. So Debbie realized one time that that was the problem when the crown kept falling off, so she went to a different dentist. She said to me, I realized one day it wasn't so much a bad tooth as a bad dentist. Kind of ironic after the fact. So here's what the dentist had, a rather small crown to work with, too much bone on the lingual, meaning there was too much gum, preventing good stability of ferrule, buccal, and lingual. You can see practically no ferrule on the mesial, but even the buccal lingual is compromised. How do we manage it? You know the answer. We manage it by doing bone reduction. And if we do that, here's what we can end up with. This is a 6-month picture and a 6-year picture. Notice that the little line in the tissue is still there 6 years later. The crown has never fallen off. You can see, somebody asked about furcations. You see how we do the bone contouring and go up and over the furcation? And look at, 6 years later, it's still there, the same up and over. The tissue is very stable. That's to answer one of the questions from earlier about, if the gum stays there, does it keep receding? No, it's very, very stable. And if you look now at the x-ray, this is what we started with, a half a tooth again. The crown is only half the size of the tooth. After we've taken the gum and bone away, the x-ray always looks different. We have a much fuller crown because we have access to the entire tooth. And here, instead of the cantilever bridge, we did a little bone graft and an implant. But we solved Debbie's problem by taking away the bone, to take away the gum, to make better retention, have enough ferrule, buccal, and lingual to have retention. So I'm hoping that that makes sense to you. The next person that walks in with a small crown like that you'll have a sense. Here's another lesson, no bite wings. Is Jake a good candidate for gum shortening? It's clear that there's a problem. We could certainly improve on it by taking away some bone, exposing more tooth. But what's the question we don't have the answer to? Is the root long enough? So please don't make any decisions without seeing a periapical. So sometimes people get referred to me and they come in with a bite wing. And I say, oh, we really don't know. We can't make a decision. We need to take some additional x-rays. And they say more often than not, oh no, wait a minute. I just paid for x-rays back at the other office. If they sent you the wrong x-ray, the bite wing, then you call them up and get the correct x-ray. Whew. I mean, they're angry. But then what we've learned to do is just take the periapical for free. Oh, how about if we take it for free, Jake? Oh yeah, of course, take as many x-rays as you want. So we do. We take an x-ray, we make sure the root is long enough. Here's an example somebody brought to class once. They just brought the bite wing. And she said, what do you think? I said, I have no idea. She went home at lunchtime, came back with the periapical, and now we can say, well, that's kind of a small tooth. If we allow 3 millimeters for biologic width and 2 for ferrule, we have to take away at least 5 millimeters of bone here. Would you do that? No, I think not. So the decision cannot be made from the bite wing, but it can be made from the periapical. And finally, a couple cases, and then we'll wrap it up. Have a sense from the x-ray. Can you see here on this x-ray? Very close to the bone. And then when you look in the mouth and see all this irritated tissue, the crown was way subgingival, like right back at the beginning, we looked at Brad, same idea, sore, angry tissue. Is it a tissue problem or is it a bone problem? Well, I think by now you can have a sense that this bone would be in the wrong place. We open it, we flap it, we take the bone away, we scallop, we take the bone away interproximally. And here again, if we wanted supragingival margins, there's enough tooth to have done it. But you see, the crowns are done, no irritation on the tissue. That was a bone problem. This was a bone problem back there with Larry, with those tiny little teeth and the tiny little crowns. So both of these x-rays are calling out to you, there's an issue. Here, that crown margin's too close to the bone, way subgingival, and Larry's is too far away from the bone because too much gum from too much bone. And the final case, I think by now it should make sense. When you go back to your offices, some of you are lucky enough to be able to go back now, just be careful, pre-procedural rinses and all that kind of good stuff, that you'll see x-rays like this. And you'll get the red flag even before the patient does. And if they bring it up, you'll understand it. So Beth's red flag was, I went to a dentist here and they told me I need new crowns, and I don't trust that dentist because I just had that crown done before I moved out here to go to graduate school. Well, I can see her questioning it, but I reassured her that the problem really was not the crown so much, but too much gum because there was too much bone. So the gum is too high. The crowns ended up subgingival with open margins. Why? Too much bone. So before, yes, I would agree. A new crown would be better with closed margins, but let's solve the bone problem. So once I explained that to her, she was okay with it. She had the gum shortening done, and you see the difference between this telltale red flag crown And the new one, just like you saw before with Debbie, bigger tooth, bigger crown, solved the problem. So there you have it, folks. Those are my thoughts. So I want to ask you if it makes sense now about the bone being these problems with these two open margins. I hope so. It's really about the bone. We set out to show you how I feel about saving more teeth, the benefits for solving restorative problems and solving aesthetic problems as well, how the definition fit into understanding of how this is a bone problem, and that by definition, crown lengthening requires a flap and bone surgery, not just a laser gingivectomy, how bone was the key, and the cases that hopefully will let you apply your knowledge. I was generous enough with my time to delude myself into thinking there'd be time for more questions, but there really isn't. I thank you for your questions, and I want to close with a couple of thoughts. Namely, you can read it yourself, but I like to read it. If you think today the way you thought yesterday, you will be left behind tomorrow. And it was my job to help you develop a new thought process. And I hope that I did a good job, and I won't be able to get your feedback right away. So if there's a way to let me know, I'd love to hear. So that was my job, was to help you change your thought process. I don't know whose job this was, but it's something to think about. So I want to tell you, I want to close with the fact that it is truly a privilege to be able to do this for Lee and for the Institute. And I had the honor of being at the Institute a few years ago to teach a workshop that was terrific, that I had that opportunity, and I'm grateful for that. It's a privilege. But I wouldn't have had this privilege tonight if you hadn't all shown an interest and signed up for this webinar. So thank you for that, for giving me the chance to share this very favorite topic that I have, and good luck with it. I'll look forward to some personal emails. You'll be able to find my name out there on my website. And thank you for being here tonight. Thank you, Lee, for giving me a chance to do this.